We call this session Quality Improvement in Upper GI Endoscopy. We think that often competency in, I was just talking to Don McIntosh from Canada, we think that often competency in gastroscopy is kind of assumed and skipped for focus on colonoscopy. So we really now, again, going to focus on gastroscopy. And we're going to have talks about how to improve patient experience. Another talk from Ralph Bishop's a live case about optimizing characterization. And then we're going to talk about structuring a service and how we can build a service which really prioritizes the patient and prioritizes the detection of those small lesions that you saw demonstrated in the previous session. So I'd like to welcome Roland Valori back to the stand to have a discussion with Matt Banks in the UK about how to improve the patient experience. Roland.
Thank you very much, David. Welcome back, Matt. What I'd like to do is just have a conversation for 5 or 7 minutes. We both have enormous experience of endoscopy. My first question to you is, have you had an endoscopy, Matt?
I have, and yes. I'm sedated.
Yes.
But I chose my endoscopist very carefully.
Yes.
And I have to say, it was a really unpleasant experience, but I managed to get through it. But I probably wouldn't go back and have it done again.
At all, or with?
Not with that colleague, but without. I'd have sedation again.
Okay.
And for 2 reasons. Firstly, it's quite distressful.
Yeah. So just can we, it may seem a very small thing, but for everybody who uses sedated as opposed to propofol-based endoscopy, the spray is quite important. And when you are intubating into the upper esophagus, do you ask the patient to swallow, or is there a reason not to do that at the point yeah?
Have you tried swallowing with a gag in your mouth?
Well, I haven't.
Give it a go. It's almost impossible. It is. You can't swallow with your mouth open. And what you tend to do is you tend to constrict your cricopharynx.
Okay.
And John and Michael very, very clearly demonstrated how you pass the endoscope to one of the piriform fossae.
Yes.
Depending on which one you go in, and then very gently, with a little bit of angulation, talk into the midline. And that's all you need to do. With a tiny amount of pressure, you don't need to ask the patient to swallow.
Okay, good. Do you have the experience of when you spray, you have a great range of response to that, from nothing at all to coughing and gagging like mad? And that's a surefire predictor whether you're going to have a problem or not. Do you have?
Yeah, absolutely. I absolutely. You can make those predictions straight off. But if you try the technique that I was taught by my anaesthetist,
yes.
you don't get the coughing and gagging.
Yes.
And you just the solution pools in the back of the throat and then they swallow.
Yes.
But you're right. Their tolerance of throat spray very much predicts their tolerance of the endoscopy if you're not using sedation. And even if you're using sedation, you require higher levels.
Do you think there are any other predictors of people who are going to have a poor experience and therefore should avoid no sedation at all costs? Excuse me. Do you? There's very old data now going back nearly 20, 30 years looking at patients' anxiety levels prior to endoscopy, males, females. The younger you are, the less likely you are to tolerate the procedure. So there is, I haven't seen any publications on those kind of demographics for years. But yeah, there are a number of predictors. Okay. So this is really my final question, Matt, really, and that is, you talked about the mindset and the whole patient journey and everything else. And I think everybody, when asked the question, was saying sedation and patient tolerance is absolutely critical here. You can't do an endoscopy when the patient's coughing and gagging and everything's moving like mad. It's absolutely impossible. So do you think we should radically change our approach to the way we prepare our patients in terms of sedation? Should we be recommending it? Do you think there are particular problems with more midazolam, less opiate in the younger patient particularly? I mean, what would be your sort of top take-home message in terms of, up to the point you're sticking the endoscope in? What would you be saying?
I
I think if you think about the pharmacodynamics of benzodiazepines and opiates, the peak effect of midazolam can take up to 6 minutes, and no one waits 6 minutes. But if you use a little bit of opiate, you reduce that peak effect to about 1 or 2 minutes. But you also suppress the gag reflex when you use fentanyl. So combining fentanyl with the benzodiazepine and throat spray, I think, very much supports the patient experience. But can I just wind back? And what I think we have to focus on, and there's not a lot of published data in endoscopy, is patient attitudes. So we really have to ask, if you look at the patient priorities, studies looking at what the patient's expectations are, what they want out of endoscopy, and you compare that to the endoscopist, it's very different. The patient wants a comfortable experience. They don't want to be distressed. They want an endoscopist who they trust, who has experience, and most of all, they want communication. And if you start the patient journey with a good relationship and you've explained, you've managed their expectations, you've explained what's going to happen, and you finish that with a well-written report that you can then talk them through, only in a few minutes, then the patient's satisfied. And if we're focusing our endoscopy on surveillance, where we know our pickup is going to be far greater than the functional dyspeptics, we're going to want these patients to come back in a timely manner. And if they're not, we're going to start missing more cancers. So we have a vested interest in investing more time into understanding patients' attitudes and expectations in terms of our outcome.
Yeah, just going to show and come back to what's so important. So let's say we're going to go straight down to the stomach like most people do, right?
You're going to do a history?
So, yeah, you go ahead.
So we have a 75-year-old female patient that was referred for a new detected lesion in the esophagus. She's a patient with a cirrhosis Child-Pugh-A with some portal hypertension, mostly in the stomach, but reported also in the esophagus. She has had a PET-CT scan, which was negative. She is in good general condition. She's on high-dose PPI. And so today is the endoscopy to evaluate the lesion in the esophagus.
So, okay. So thank you, Peter. And sorry for being so fast. So just going to come back to the fact that if you're going to go straight down in the esophagus to the stomach to check for the varices, like you might want to do in a patient like this, you go too quick, no insufflation, right? So many people do it like this. And then you have you check and say, oh, this looks nice, there's no varices. So we check that, we clean everything. But now we're going to do the same with sufficient insufflation, right? So basically, the esophagus was collapsed. So, I mean, we can talk about characterization in a minute, but that's very, well, expert level and when you're deciding on doing therapy or not. But now look, we're going to do the same with a slow withdrawal, and we come by a lesion we definitely passed on the insertion, and now you clearly see something, right? So this should draw your attention. You can see the difference in color pattern, even with white light, that something is there. And very often people report this as candida, right? So that's a common mistake, and I think we should use the correct terminology. I mean, if you see something like that, it's suspicious, right? Something's going on, there's fibrin, and it's definitely different from the area. Now let's do the same again with, in this case, BLI. We have LCI, so BLI is what's comparable to narrowband imaging. And you can see this lesion will stand out immediately when you do a slow pull through. So you need to make sure, like in the colon, you inspect everything. And look now, this is much clearer. So you can clearly see there's something going on. And when you see this, then you need to realize that this is cancer until proven.
I agree with that, John.
Yeah, I totally agree with that in the esophagus. Do you think they've biopsied it here already? You see there's a difference between the slightly hypervascular
It has
area
been biopsied. It has been biopsied,
and then you move into a different area here, which is actually almost hypodense, where there's a change again.
Yeah, this is the second feature of squamous cell cancer. So we have the irregular dense IPCLs, and then you have the avascular areas. And I must say that in this lesion, the avascular area is quite big.
Yeah.
So this is, well, a little bit cumbersome. Also, it's in the 2C area, so I expect that there may be superficial submucosal invasion, but for sure you can still see IPCL shining through, so I would definitely go for staging ESD here to do that. But so these are the two features, the avascular regions like here, and then the dilated IPCLs next to each other.
And how many biopsies would you take, Raf?
I think, you know, if you take a biopsy, like for instance of this area, which is most striking, that should do it. And then if dysplasia comes out, you need to proceed to resection it. I mean, the decision between surgery, radiotherapy, or endoscopic therapy is based on what we do now. So this is the crucial part. Not even an endosonography. Obviously, we always do a full staging for these lesions because they have other risk factors for lung cancer, and these lesions metastasize easier. But the main decision is based on the aspect of the lesion. That means the Paris classification. Here is it's a 2B, 2C lesion.
Great, David. Thank you very much. First slide, please. So I really want to focus here on how you clearly see the mucosa, all the steps that you need to take to get there, rather than very in-depth mucosal patterns or IPCL. So next slide, please. Disclosures. Next slide, please. So it's all in print. There's very good guidance on how we should perform high-quality upper GI endoscopy. So I please encourage you to read the European, and if you want, the UK and US guidance. They're very similar. Next slide, please. So what are the most important outcomes? Well, you've got to think it in terms of the patients, what their objectives is, and the endoscopist. And as I mentioned before, the patients want to be comfortable. They want you to have a high level of skill and focus, and they want high levels of communications. Whereas the endoscopists, they focus on mucosal visualization, pathology detection, or the accuracy of the test, patient safety, and interestingly, list efficiency. Next slide, please. So these are my top 10 tips. You've heard many of them already, and I'll run through each one individually. So next slide, please. So optimizing your environment, you need to be comfortable. And as John demonstrated in the last live demonstration, the stat needs to be in the right position.